Okay, thank you all for being here. So we're gonna talk about a very hot topic today. It's about Ebola virus or Ebola hemorrhagic virus disease. Let's start with a little bit of background about the virus itself. So Ebola virus is a filovirus, as well as Marburg virus. These are uncommonly encountered, but when they are encountered, usually is when there is an outbreak. The name of the viral family comes from their characteristic thread-like morphology. Philo for Latin means filament, and when they can be recognized in tissue samples, and that's the way they can be recognized because of their thread-like morphology. They are enveloped, non-segmented, negative-strand RNA viruses. And like I mentioned, it includes the Marburg virus, Cueva virus, with a single species each of them, and the Ebola virus has 5 distinct species. All non-African Ebola viruses can infect humans and can cause similar symptoms, but they vary in terms of disease progression and virulence, and their fatality rates also vary, ranging from less than 40% for the Bundibugyo Ebola virus to approximately 50% for the Sudan Ebola virus, and up to 70 to 90% for the Zaire Ebola virus, which is the one that is currently affecting the west side of Africa. The virulence of Tay forest Ebola virus is difficult to assess because it has been only a single case recorded. Also, the Reston Ebola virus can infect humans, but is asymptomatic. So, in general, they're elongated structures, about 80 nanometers in diameter. The basic length of the replicative form is 790 nanometers for the Marburg virus and 970 nanometers for Ebola virus. They also form long branching structures. Like we talk about, there's 5 known species of the Ebola, and they all share some certain degree of cross-reactivity by ELISA. The 4 of the 5 that cause disease in humans is the Zaire Ebola virus, the Sudan, the Thai forest, and the Bundibugyo. The 5th, which is the Reston virus, has caused disease in monkeys or macaques, but not in humans. It can infect humans, but it hasn't caused disease. So this is a nice picture of the virus itself. This is from the New England Journal of Medicine. We can see its filamentous shape here. It's negative strand RNA. That is surrounded by the nucleocapsid. It also had the trimetic glycoprotein spikes on the outer membrane and the matrix proteins close to the nucleocapsid. The natural history of the virus remains a mystery. Each filovirus case or epidemic has been investigated for the source of the virus, but without success. In the case of epidemic, it has usually been possible to trace the epidemic back to a human or non-human primate index case, but no further. Among the suspects, there are the spiders, ticks, bats, and monkeys. But again, there's no evidence to point to a specific one. 2 epidemics of the Marburg virus, with a series of primary infections originating from cave exposures, and this combined with reverse transcriptase PCR, positive reaction from bats. And a specific type of bat is the Rosetus aegypticus, and suggestion of prolonged infection in experimental infected bats place the fruit bats as a focus of interest as possible reservoirs of the Ebola virus. The first case was recognized in 1976 when two unrelated epidemics occurred in northern Zaire and southern Sudan. 88% of the patients out of 318 recognized cases died in the one in northern Zaire, and 53% out of 284 cases in southern Sudan died. Then the disease recorded in the same area of Sudan in 1979, but the virus was not recognized for almost 2 decades. Then again in 1995 and 1996, it was again recognized in different outbreaks. An additional Ebola subtype was isolated from a human patient, and 3 separate Zaire subtypes epidemics were recognized in Gabon, with a major epidemic having 315 cases with 81% case fatality rate from the Zaire subtype back then. In 1989 and to 1991, another subtype was discovered in Western Virginia, and this was among monkeys imported from Manila, Philippines. The virus was highly virulent in macaques, but the caretakers were infected but didn't suffer disease, so it just infected the monkeys. In 2009, an outbreak of the Reston Ebola virus was discovered in pigs in the Philippines, and there was also evidence of antibody infection in human infection was also found, but not disease. The route of transmission. The exact route by which the filoviruses may be spread are not known. Of course, parenteral inoculation with contaminated needles or syringes has been efficient and carries an enhanced mortality. Also, skin and mucous membrane contact with virus-laden materials has probably been responsible for most of the recognized human infections. Also, experimental studies of filoviruses establish that they are stable and highly effective in small particle aerosols, and observation of intermonkey transmission have suggested aerosol transmission. Nevertheless, airborne infections plays a minor role, if any, in interhuman spread. But however, right now, when there's a suspected case of Ebola hemorrhagic fever, the recommendations are to use contact and airborne isolation, because little is known about this virus. Right, you don't want to take any chance because you don't know with what you're dealing. Right, barrier nursing. So these are zoonotic pathogens. They are presumably carried by various species of fruit bats. These are the theories present in through Central and Sub-Saharan Africa. And again, in contrast with the Marburg virus, whose reservoir has been identified, as the fruit bat, Ebola viruses have not yet been isolated from bats that have molecular and seroepidemiologic evidence of infection. Introduction into the humans most likely occurs through direct contact with bats, or their excretion or secretions, or through contact with other end hosts, such as the great apes. So, playing with monkeys. Okay. Human-to-human transmission is what leads to outbreaks, which are often started by a single introduction from the wildlife reservoir or another end host that involve various variants with little genetic diversity, as in the current outbreak in West Africa. So this is a nice picture from the CDC representing the theory of how the virus can be spread to humans. It can be directly from, presumably, from the fruit bat to a human host, or to another host like a non-human primate, and then to humans. Usually when there's infection among non-human primates, that is what precedes the human outbreaks. And once one human host has it, it starts the outbreak. It's very easily, very contagious. So the clinical manifestations commonly present with non-specific symptoms as fever, vomiting, and severe diarrhea with visible hemorrhage, occurring in less than half of the cases, as in the current outbreak. Again, not all the cases has hemorrhagic fever. You will see this in about 50% of the cases. But from all the source of information, I read that in the current outbreak, most of the patients were having vomiting and severe diarrhea. They have an incubation period of 5 to 10 days and begin again with abrupt absence of fever, with myalgia and headaches. Some other symptoms might be abdominal pain, chest pain, cough, and pharyngitis, photophobia, lymphadenopathy, conjunctival injection, jaundice, and pancreatitis. CNS involvement can be manifested by somnolence, delirium, and coma. Then, as the disease progresses, wasting becomes evident, and then the bleeding manifestations such as petechia, hemorrhages, ecchymosis around needle puncture sites, and mucous membrane hemorrhage occur. Again, in half or more of the patients, not in all of them. Around day 5, most of the patients will develop a maculopapular rash, most prominent on the trunk. And by the second week, the patient can go either way. They can improve significantly, or they can die from multi-organ shock with DIC, anuria, and liver failure. Some clues to make a diagnosis: recent travel to rural sub-Saharan Africa, or exposure to non-human primates, thrombocytopenia and leukopenia, elevated LFTs, usually AST is more elevated than LLT, elevated amylase and D-dimer are common, and the rash. So again, if a patient has early symptoms of Ebola hemorrhagic fever, and there's a reason to believe that this diagnosis should be considered, the patient should be isolated and the public health professionals notified. And then the samples from the patient can be collected and tested to confirm the infection. Culture is positive during the acute stages, and seroconversion occurs around day 8 to 12. Antigen detection, or RT-PCR, provides a practical and sensitive method of diagnosis. IgM antibodies can be useful in the early convalescence. IgG serologic testing is not as reliable because there's a lot of false positive. And again, these are the laboratory tests used in diagnosis, divided by time frame. Within a few days after symptoms began, we can use ELISA, IgM ELISA, PCR, virus isolation. Later in the disease course of after recovery, we can use serology, mostly IgM. And retrospectively in diseased patients, we can use histochemistry testing, PCR, and virus isolation. Treatment. Well, there's no treatment available so far. There's some vaccines and antibodies that can be used. Vesicular stomatitis virus-based construct using Ebola sire or Marburg, successfully protected mice and monkeys, including post-exposure treatment in some settings. But this type of construct has never been used in human. Also, a prototype adenovirus vaccine expressing this antigen has successfully protected monkeys and demonstrated a good safety profile in phase 1 studies in humans. So the management is mostly supportive, avoiding minimal trauma, IV fluids, realizing the possibility of myocardial compromise and increased lung vascular permeability, or ARDS, replacement of coagulation factors and platelets if it's indicated. The prevention of epidemics rests on early recognition of initial cases and prompt institution of barrier nursing, but this is hard to recognize most of the cases. Properly sterilized injection equipment, protection from body fluids and skin contact during preparation of the death, and routine barrier nursing precautions. Once again, there's currently no licensed prophylaxis or treatment for any Ebola virus or Marburg virus infection. Therefore, treatment is merely supportive. The current front runner for the therapeutic intervention seems to be antibody treatment, which has been successful in macaques, even when antibodies are administered more than 72 hours after the infection. So, this is a picture from the CDC showing the barrier nursing that they're using now in Africa, which is wearing protective clothing such as masks, gloves, gowns, and goggles, the use of infection control measures such as complete equipment sterilization and routine use of disinfectant, and of course putting the patient of isolation. The aim of all these techniques is to avoid contact with blood or any body secretion of an infected patient. Also, if the patient is deceased or died, it's equally important the way how the body is handled. So, moving to what is going on right now, the current outbreak. So this is a map from the west side of Africa showing the areas of the current outbreak. As you can see, the red areas are the areas with confirmed and suspected cases, and the beige areas are suspected cases. So it's pretty much Guinea and Liberia. So as you all are aware, in March 2014, the World Health Organization was notified of an outbreak of a communicable disease characterized by fever, severe diarrhea, vomiting, and with a high fatality rate in Guinea. The Ministry of Health of Guinea reported on May 3rd, a week ago, a cumulative total of 231 suspect and confirmed cases of hemorrhagic fever, including 155 deaths. So the fatality rate is close to 70%. Of these suspect cases, 127 have been laboratory confirmed positive cases of Ebola hemorrhagic fever. And the number of healthcare workers reported among the suspect and confirmed cases is 24, including 16 deaths. Other districts with report of suspect and confirmed cases remain on Kakedo, Macenta, Kizidogo, Dabola, and you can read that. Anyone? No? The Jingareya? Okay. Got it. So according to the World Health Organization, the Ministry of Health and Social Welfare of Liberia reported no change to the 13 suspect and confirmed Ebola hemorrhagic fever cases, including 11 deaths in Liberia as of May 2nd. That was last week. 6 samples were positive for Ebola virus. Samples from Mali and Sierra Leone have thus far been negative for the virus, although they're still monitoring suspect cases that are ongoing. So there was an article published 2 months ago in the New England Journal of Medicine that actually Dr. Green sent out. So they were trying to trace the origin of the infection. So, and they tried to demonstrate the emergence of a new Ebola virus strain in Guinea, which actually is the Zaire type, which is the one with the highest mortality rate. So, like I said, they tried to establish the geographic origin of the outbreak. They used conventional Filoviridae specific reverse transcriptase PCR assays targeting a conserved region in the L gene to test samples obtained from 20 hospitalized patients who were suspected of being infected with the Ebola virus. Samples from 15 out of 20 tested positive in the conventional L gene PCR assay and the real-time assays. So pretty much the study concluded that the high degree of similarity among the 15 partial L gene sequence along with the 3 full-length sequences and the epidemiologic link between the cases suggests a single introduction of the virus into the human population. The suspected first case of the outbreak was a 2-year-old child who unfortunately died in Maliandu around December 6, 2013. So according to the research that they did on the demographic data, it traced back to that case. And that's pretty much it.